Hello everyone, welcome to HIM 216. This is the first in a series of lectures for Chapter 8. We'll be covering Chapter 8 this week as well as next week, and we will have many lectures covering this chapter. Chapter 8 is on page 140 in your textbook, and it actually is coding medical and surgical procedures. So when we are looking at the procedure tab in 3M, we're talking about all codes that begin with a 0. So medical surgical, we're talking about the section 0 medical surgical, which is primarily where you will be coding from when you're coding. Make sure to review the abbreviations and acronyms that are listed for you on page 140. And at the end of the chapter, you want to be sure and look at those glossary terms. There aren't that many of them. And then, as always, I suggest that you review the homework assignment before you begin reading the chapter and listening to the lecture. For Chapter 8, your homework in the chapter review exercises, you're going to be answering the odd questions 1 through 11, and then you have a workbook assignment which includes glossary definitions and multiple choice questions. So let's take a look at Chapter 8, and because we're talking about coding procedures here, we're reviewing the UHDDS definition for a principal procedure. And the principal procedure is the one that was performed for definitive treatment rather than for diagnostic or exploratory purposes, or one necessary to take care of a complication. If there are two procedures that meet the definition, the one that is the most closely related to the principal diagnosis is the one that we are going to choose as our principal procedure. Now we have a little green box here that talks about the guidelines and the selection of the principal procedure. And basically what these tell you over and over again is you select as the principal procedure, the procedure that is most related to the principal diagnosis. So as we look at these, if we have a procedure performed for definitive treatment of both a principal and a secondary diagnosis, then we sequence that procedure that was performed for the principal diagnosis as the first listed or principal procedure. If we have, number 2 says, if we have a procedure performed for definitive treatment and diagnostic procedures performed, and they're both for the principal diagnosis, then we sequence the procedure that was performed for definitive treatment that's most related to the principal diagnosis as that principal procedure. And then number 3 tells us that if we have a diagnostic procedure that was performed for the principal diagnosis, and a procedure is performed for definitive treatment of a secondary diagnosis, in this instance we are going to sequence that diagnostic procedure as the principal procedure because it will be most related to the principal diagnosis, and that takes precedence. So basically, the procedure performed that is most related to the principal diagnosis is the one that takes precedence, whether or not it was definitive or diagnostic. That's the consistent theme for 1 through 3. 4 is a little different. In number 4, we did not perform a procedure related to a principal diagnosis. The procedure performed for definitive treatment was for secondary diagnosis, and then there were also diagnostic procedures performed for secondary diagnoses. In this instance, we are going to sequence the procedure that was performed for definitive treatment of a secondary diagnosis as the principal procedure. So we have 2 scenarios going on here. We have procedures that may be performed that are related to the principal diagnosis. When we do, the definitive procedure is sequenced first as the principal procedure. If we have a secondary diagnosis and we have a diagnostic procedure performed and a definitive procedure performed, and the diagnostic procedure was the most related to the principal diagnosis, then that's the procedure we choose as the principal procedure, even though it was diagnostic. And in that case where we have procedures performed that are not related to the principal diagnosis at all, we would choose the definitive procedure as the principal procedure. So just take some time to read these. Definitely this is note card material for you, and it just takes time looking at it and reading it and making some notes to really get it straight in your head. Now, the other thing we need to talk about on page 141 is what a significant procedure is. And we only report significant procedures unless it's a procedure that will impact reimbursement, such as a patient being put on a ventilator. A significant procedure is surgical in nature. It has a procedural risk, it has an anesthetic risk, and it requires special training. An X-ray is typically not ever coded in PCS and listed on an inpatient chart as a principal procedure. So do not make that mistake. We don't code X-rays and CTs and MRIs and put them on a chart as a significant procedure. Those codes are CPT codes that come from the charge master. Nursing procedures such as starting an IV, putting in a urinary catheter, those are not coded. They are not significant procedures. They're not surgical in nature. There's no anesthesia associated with those, and the training is part of the nursing training. It's not additional specialized training in addition to being a nurse. Now, the important thing about a significant procedure, it does not have to be done in the OR. It can be done in the emergency room. It can be done before admission. It can be done at bedside. It can be done in a patient treatment room. It can be done in interventional radiology. Sometimes these procedures do not have a procedure note, an operative report, and they're easy to miss. There definitely should be physician documentation. Sometimes they write a procedure note, sometimes they write it in a progress note. We had a pulmonologist that used to do bronchoscopies at bedside, and he did not dictate an operative report. Those patients were usually on ventilators, they were sedated, and he would do the bronchoscopy right there at bedside. We found that documentation in the physician progress notes. Typically, you will find a consent for procedures in the chart, but just because there is a consent, it doesn't mean the patient had the procedure done. But it definitely is something that you would look at and then search the chart to see if in fact the patient had the procedure. So you really have to review that whole chart. Now, some of the things that UHDTS requires as far as data reporting, and this is part of the abstracting process, is the date of the procedure. So when you're coding and you're abstracting, you're also pulling out the date of that procedure. You're also identifying the physician that performed the procedure, and by doing that, the system will pull through his national provider number so that that claim can be billed. Those are required data elements. On page 142, any procedure that affects payment or reimbursement has to be coded. If it's not coded, it's not reported, and subsequently the hospital won't be reimbursed for it. I worked as a coding auditor for many years, and I would find patients that I would go in and review charts of patients that actually had had a cholecystectomy, and yet it was never coded and billed for. Patients who were placed on ventilators, and the ventilators were never coded and billed for. So you have to be very careful when you're coding. If you don't code it and it's reimbursable, the hospital is not going to be reimbursed. There's an example on the top of page 142. Lysis of adhesions is typically a procedure that we do not code. Adhesions are scar tissue that is in the abdomen. They can develop from previous surgery, or they can develop from an infectious process. And usually when a physician is going into the abdomen and doing surgery, if there are adhesions, he may document that he took down the adhesions. But that's considered to be a normal part of the procedure. However, there are circumstances when the adhesions are more than expected. They require more time and more effort on the part of the surgeon. And when those situations occur, he usually goes into detail about the extent of those adhesions and what was involved in actually resecting them, taking them down, and they call it taking down adhesions. And if you are going to code the fact that the surgeon releases those adhesions, you should have a corresponding diagnosis code saying that the patient has adhesions. Now, CMS has a tool called a Medicare Code Editor, and that Medicare Code Editor alerts the coder about certain codes, maybe when they're when they don't impact reimbursement, or even when they do impact reimbursement. And as we go through the rest of this textbook and work with the grouper, we'll see those alerts, so we'll be going over those more as we progress through the course. Every facility should have written policies about assigning ICD-10 codes. And this little section does tell you that procedures that are easy to overlook are things like mechanical ventilation, debridement, usually this would be a non-excisional debridement, lumbar punctures, also called spinal taps, suturing wounds, ECOM, and then procedures performed by interventional radiologists. Those may or may not have ICD-10 codes. Let's look at bilateral procedures. A bilateral procedure is when the same procedure is performed on paired anatomic organs or tissues. And these can be things like eyes, ears, joints, shoulders, knees. And according to the guidelines, if the identical procedure is performed on contralateral body parts, meaning right and left, and there is a bilateral body part value available, then you assign it. If there's no bilateral body part value, then you have to code them separately, like left and right. You can think this is kind of like with acute and chronic. If we have a combination code for acute and chronic, we assign it, otherwise we have to assign the code for acute and then assign for chronic. Well, the same thing applies to bilateral procedures. If there is a code for a bilateral, you use it, otherwise you're assigning right and left. And so as an example here, they have an example of an inguinal hernia repair, and you'll see that under body part. Here it says inguinal region bilateral. And then at the top of page 143, this is an example for a patient who's having both knees replaced. There is not a code for bilateral knee replacement. Hold on just a second. And this example on the bottom of page 142, this is inguinal hernia repairs. So when we're in repair, inguinal, and you can see that there is a code for bilateral, 0YQA, and then once we get to that table, we choose our approach, and there's no device and no qualifier. On the top of page 143, you will see that this is a replacement. And if we do replacement, I think we have to do replacement joint knee. And you'll see we have left and we have right. We do not have bilateral. So your question for this lecture is I want you to go and look at resection of ovaries and resection of fallopian tubes, and I want you to tell me if there is a bilateral code for ovaries and a bilateral code for fallopian tubes, and if you find that there is, I want to know from the index what table does the index send you to. I don't want the full code, I just want to know what table the index sends you to. And that will conclude this first lecture for Chapter 8.